So, welcome everybody. This is my deep pleasure and honor to introduce Dr. Judith Herman. She's a psychiatrist, teacher, and researcher, and one of the most influential voices in the study of trauma. A professor of psychiatry at the Harvard Medical School, Dr. Herman's work has changed the way we understand psychological trauma, especially the trauma arising from violence, abuse, and political terror. Her groundbreaking book, Trauma and Recovery, originally published in 1992 and now in its fourth edition, published in 2022, now in upcoming Spanish language version in 2025, bridge the worlds of private suffering like incest, domestic violence, and rape with the public traumas of war, torture, political repression. Her approach is interdisciplinary, human-centered, and deeply ethical. Dr. Herman's conceptualization of complex trauma and her development of a stage-based model of recovery, safety, remembrance and mourning, and reconnection have been foundational in both clinical practice, research, and activist spheres. So let us welcome Dr. Judith Herman here. Welcome, Doctor. Glad to have you with us today. Thank you.
Thank you very much for having me.
Yeah. So I wanted to invite you for a short conversation around your book, around the nature of trauma and the roots of the work. You begin Trauma and Recovery with the observation that ordinary response to atrocity is to banish them from consciousness. What drew you to face the unspeakable so directly? What brought you to this deep realization?
Well, I don't think it's just one thing. I think probably first of all, I'm a war baby. I was born in 1942 in the middle of World War II. I'm also second generation American born child of immigrants fleeing persecution in the Pale of Settlement in Eastern Europe. And then my parents also suffered political persecution during the McCarthy era in the United States. So I certainly grew up with a strong awareness of the dangers of tyranny and the need for movements for social justice. And then I was involved in the civil rights and anti-war movements in the US during my young adult years, and then very involved in the women's liberation movement. And it was, I participated in a women's consciousness raising group the very same time that I was beginning my psychiatric residency. And so that really raised my awareness of gender violence. And my first two patients, when I began my residency, were incest survivors. And it wasn't hard to make the connection between the abuse they had suffered as children and their suicidality that got them hospitalized. And so that kind of set me on a path.
Amazing. Yes, it's very, when I was going through the book and you talk about how how the perpetrator is almost entitled to do what it's doing, and you also touched the concept of the morality crisis of the bystander, in how the victim needs to find I wrote it down, action, voice, something to really come back to this, to be visibilized again. And this comes into this perspective, right, on how you were dissecting in your book how previous clinical thought, when a woman was suffering from some kind of strange behavior or hysteria, it was treated as a disorder. But this is where you bring about the trauma, how her being abused has really turned into something uncontrollable or unspeakable, as you say, right? And is
Yes, I mean, and the issue of the bystander and whose side the bystander takes was, of course, front and center in the literature about the Nazi Holocaust. You know, it was one thing for you know, the Nazis to be persecuting Jews, but where were the bystanders? Where were the people on the sidelines who could have intervened and didn't? And that, of course, was the same dilemma that we saw with the incest survivors. Where was my mother?
exactly, exactly. And this brings the first part of the book. You make a very cohesive introduction to what traumatic disorders are, from your experience, from all this bringing together experiences, clinical work, research, historical foundations, early child circumstances and abuse. Can you elaborate a bit? Of course, this is a very short interview. Wanting to summarize all of this is, I know, but what would you say about this?
Well, I think one way to summarize would be to say that traumatic disorders are disorders of terror. And I think that was one of the early ways that PTSD was conceptualized as an anxiety disorder. But I think that's a very limited formulation, because I think there are also disorders of shame. And both terror and shame are hardwired survival responses. And it's easy to conceptualize PTSD as an order of the fear system, with the, you know, being on alert for danger all the time, and the hyperarousal, the startle responses, the intrusive memories of it, so that the fear response, the fight or flight response, and then the freeze response when fight or flight are useless. You can think of those as the fear system on permanent alert. But trauma is also a relational disorder. And I think the shame system, which is also hardwired and fast acting, tells us when there's trouble in a relationship, when our safe attachments are no longer reliable, or when people who we look to for care and protection are hurting us, or ignoring us. And so you have all the features of disordered shame, the humiliation, the self-blame, the sense of defilement and contamination, the sense of a dirty identity, and the unstable relationships that result. These are also a big part of the traumatic syndrome.
Yes, yes. Yes, and how important it's coming to the surface after your first edition and all these years that you wrote, and now it's the fourth edition. How trauma is now slowly being more recognized as a causation of human suffering, and the way to treat trauma first, and then whatever else. You're right.
Well, yes, I mean, there has been, I think, a lot of progress in awareness of how common trauma is, and what some awareness of what the symptoms are like. I don't think there's been any comparable progress in prevention.
No, unfortunately, no. And still, as I was reading chapter 7 on the healing relationship and safety, I was very touched, because you so really emphasize the therapeutic relationship, and how psychotherapy is such a slow process for what's actually needed in the size of the world right now, and the populations needing assistance.
Yes, we don't have a magic bullet. We don't have penicillin for trauma. The good news is people really do get better with good treatment.
Yes, yes.
And the bad news is the treatment takes a while, because trust has been destroyed in people who've suffered trauma, and you need to rebuild it. And that you can't do that overnight.
No.
That's a trial and error kind of process.
Exactly, and you also mentioned the countertransference in the. Could you speak about it, and the transference in your chapter 7? I think this is very interesting for the people who come to our site to listen.
Well, one way to think about this is that trauma is contagious, and that we suffer a secondary traumatic stress syndrome as witnesses, or vicarious traumatization, it's been called. And the countertransference kind of mimics the traumatic disorder, in the sense of it can either involve hyperarousal, getting sort of too intrusively over-involved, or numbing and withdrawal. and distancing ourselves from the patient, being judgmental, being dismissive, blaming the victim, and so I advise people who are working with trauma, just never do this work alone, because isolation is toxic and you need your own support system just as the patient does.
Exactly.
And so, you know, one of the things that kept me going all these years was my colleagues at the Victims of Violence program at Cambridge Hospital, which was the trauma program we started, because they were wonderful. And, you know, there was always a shoulder to cry on, and also people to laugh with, and, you know, go out and walk the dog with, and
Yeah. Return to life and to aliveness and to
and appreciate the good things in life.
yeah. Yes, I really appreciate reading this, how this is a very clear reminder for all of us who are therapists and of some kind of therapy and working with trauma, how we need support, how we are affected by working with trauma, and how we need to weave our integrity as well for ourselves and for the patient. And that's what I would like to ask you. Your reflections on integrity are very paramount on the book. Could you share them here if you have them handy?
Can you clarify? I'm not sure exactly I understand your question.
Yes. You were talking about the integrity needed to do this work on behalf of what's needed for a therapist and for the client in terms of integrity. Yeah.
Well, it's interesting. I mean, Erik Erikson conceptualizes the central conflict of the last stage of life as integrity versus despair, and because and wisdom as the virtue of that stage of life, and certainly if you're dealing with trauma, you're bearing witness to the most horrible things that you can imagine, you know, that things you would never dream one human being would do to another human being. And you think you've heard it all, but some patient is going to tell you something that you just, is just going to be beyond your wildest imagination, and horrifying. And so what protects you from despair? I think, well, my mother, who was a psychologist and psychoanalyst, used to say that activism is the antidote to despair. That she thought that joining with other people to try to make a better world was what gave people hope and overcame that sense of being a helpless bystander, of powerlessness. And so I've tried to follow her advice to the best of my ability.
Oh, yes, you have. Yes. So, from this place of your experience with activism, could you speak about what is your understanding of moral injury?
I think moral injury, the way I understand it, is being in a situation where you are being asked to violate your own moral principles, and forcing people to do that is one of the most powerful methods of coercive control. And these are methods that are used worldwide because they work. They're methods that are taught from one, secret police force to another. They're methods that are taught by pimps in the sex trade. And I think that's probably how the batterers and the incest perpetrators learn, and learn these methods. But making someone do something to harm another person, or to be basically complicit in crimes is a way to really break a person's spirit.
Yes.
And you hear, and it's interesting, for example, one of the studies that came out, we had a long prospective longitudinal study in the US called the Vietnam Veterans Readjustment Study, and following Vietnam veterans after they returned from the war over a period of years. And there was a subgroup of about roughly 10% of the veterans who they called the harmers. They had either harmed prisoners of war or civilians, oftentimes following orders, or sometimes just in an angry rampage, where a whole group of soldiers had gotten out of control and burned down a village. And they were among the harmers turned out to be among the most severe cases of PTSD. They had, the most severe and prolonged PTSD symptoms. So they, for most, in most cases, they suffered no consequences in terms of any formal accountability for war crimes. But they did suffer from their moral injury. And in the private realm, you see this all the time with, for example, women who are victims of intimate partner violence, who will bargain with the abuser and say, okay, you do anything you want to me, just don't hurt the kids.
Okay.
But, then he will hurt the kids. And by that time, she's so terrorized that she doesn't intervene. Mm-hmm. And that is, that's the equivalent kind of moral injury.
Yes.
Or, actually forcing, in prostitution, for example.
Yeah.
People who are already prostituted will be forced to participate in beatings of the new recruits.
Yeah. It's breaking a person's will in a certain direction.
Yes.
And
they'll be forced to be accomplices.
Yeah.
And that is the ultimate way of breaking a person's spirit.
Okay. And you, together with this, you have a proposal of restorative justice, right? Can you follow up on this?
Well, my new book, Truth and Repair, is based on interviews with survivors about what justice might look like if they had any say in the matter, which by and large they do not. The justice system as we know it is not designed for them. And certainly with victims of gender violence, has a very, very poor track record in terms of, say, rape, where though it's in theory considered a felony, a serious crime, in practice, maybe 5% of rapes result in accountability in the justice system. Probably less than 5%. I mean, the latest data estimates I've seen are something like 2.8% in the US, and I don't think it's any different in other countries. And so, there is this alternative concept of justice coming out of pacifist traditions and indigenous traditions, in which rather than in which repairing the harm done rather than punishing the offender is the metric of justice. And it's a negotiated, it's a, rather than an adversarial process, it's a consensus process in which the victim, who is called the harmed person, and the victim's supporter are invited to enter a peace circle with the perpetrator, called the harm doer, and his supporters, and it's facilitated by a restorative justice practitioner and other members of the community. And the idea is for the harm doer to apologize, to acknowledge what he's done, apologize, and agree to a plan for making amends. It's entirely voluntary. There's no enforcement mechanism, and there's also no fact-finding mechanism. So it depends entirely on the willingness of the perpetrator to basically confess.
Yeah.
The incentive being that rather than facing punishment, the harm doer faces what one of the theorists of restorative justice calls reintegrative shaming, being denounced by the community as a preface to repair, rejoining the community by making amends. So it's a very interesting model. It's mostly been implemented for nonviolent juvenile crime in places like Australia, New Zealand, Canada. it's quite controversial about whether it could be adapted for violent crime. And there's some interesting models in which it has been kind of integrated into the conventional justice system as a diversion program, so that there is ultimately some enforcement mechanism as backup. But it's very, very much a work in progress. The other place I think it's been adapted is on places like college campuses, where there's a strong argument for sort of keeping rather than expelling the perpetrator from the community and where he's just going to go do it somewhere else, keeping him, you know, if it's a young person, a first-time offender, not premeditated, is there, you know, is this going to be a good learning experience if the, you know, there's an accountability process that involves apology, acknowledgement, apology, and amends. Imagine if he can bring his whole sports team or fraternity along, you know, to educate them. So it's an interesting idea that that captures more, I think, of what survivors might want, but to be developed.
Yes, yes, very interesting. As you were speaking, it came to mind that recent Netflix series on adolescence, where there's a child that murders a companion and he's in the probation system in Britain. And it's kind of similar, but doesn't reach that restorative justice place.
Yeah, and of course, the highest risk age group for sexual assault is adolescence and young adulthood. So, so, you know, the earlier you can do your intervention, perhaps the more preventive it might be.
Yes, 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 yes. Absolutely. Thank you so much for this. And you also talk about the three stages of safety: remembrance and mourning and reconnection. And I think much of the work now being offered here, for instance, we have worked extensively with Stephen Porges, with Deb Dana, on regulation of the nervous system. And then we also have worked with Ruth Lanius and Bethany Brown on creating solid ground for patients who present highly dissociation. And this, of course, matches a lot of your safety proposal of stabilization phase, right? But the processing, the remembrance and mourning, could you elaborate a bit more about the second phase of your model?
Well, sure. But I do want to emphasize that
Yes.
the importance of safety as a really establishing safety before venturing into the deep trauma processing. And unfortunately, a lot of behavioral models don't do that. And I think that's one reason they have such a high dropout rate.
Yes, yes.
Because if you don't feel safe in the present, then you can't say that was then, this is now. You can't make that, you can't calm yourself down by saying it's over.
Yeah.
I'm not at risk anymore. I'm not in danger now. And safety isn't, you know, begins with the body, regulating sleep and eating cycles and moving out from there. But it's also very much a social project because no one is safe in isolation. And so we pay a lot of attention to money and work and the structure of the day, and then of course also people have to be safe from themselves. So that means addressing things like substance abuse, which is such a common complication of PTSD, and self-harming behavior and eating disorders and so on.
Yeah.
But when there comes a time when people are pretty well stabilized in the presence, and then if they are willing, and so some people want to just drop out of treatment then. I mean, I've had patients who said, I know what, I know what's coming up in terms of facing the past, and I don't want to do it. I want to just go live my life. And you say, well, okay, maybe now's not the right time.
Exactly.
But assuming they're willing, the focus really does shift to the past. And this is when people, it's not that they never talk about the trauma in the early stage of recovery, but getting into the gritty detail, the smells, the sounds, the feelings, the emotions, all of that. And also all the secret parts. Yeah, but I went back for more.
Yes, so it's a long process of going into this direction. And I don't know, as you say, many people want a very quick entering into the therapy, and also many possibly young, immature, or therapists don't know, they want to work immediately with their tools. And then we skip, or they skip that phase of stabilization that's so necessary to build a foundation. So you propose that it be explicit for trauma therapists and trauma patients to agree that there need to be this phase as part of their treatment program.
And the early recovery is also a good time for skills building, breathing exercises for people who can use them, the yoga for people who can use it. I mean, whatever works.
Yeah, grounding work, visualization, breathing.
But and then, because then when you do the in-depth work, the PTSD symptoms are going to come back.
Oh yes.
And you try to keep that within the range of tolerance.
Yes.
So and a lot of patients imagine that it's going to be like an exorcism.
Yeah.
They're going to vomit it out and bleed and scream.
And that's it. Yeah.
And it's not like that.
No.
It's a little bit at a time, processing a little bit, and then, because the idea is to integrate it into a life story. It's so that the trauma is not the whole life story anymore. It's a part of a life story. And to really, traumatic memory is, it's often not, it is abnormally stored. It's not like normal narrative memory. It's not, a normal narrative memory is something like, you could say, your high school graduation. And I haven't thought about my high school graduation for 60 some years, but, I could remember and if we're in a high school reunion, you can bring up a bunch of memories and then you put them away and you don't think about it again.
Correct. Yeah.
Trauma memories are not like that. They pop in when you don't want them. You can't get them when you do want them.
Okay.
They're not normally stored, but the processing of the memory bit by bit actually does, and we have the neuroscience to show this now, it modifies the memory storage so that it becomes a narrative memory.
it can go back into an event. Yes, yes, yes.
Yes, and then so you can say, yeah, it happened, it's over.
Yeah.
Um, and at a certain point, I mean, people think it's going to go on forever, this work. And it does involve a lot of grieving
Yeah.
for all the things that were lost that cannot be recovered.
The grieving process is very long normally for, yeah, right, is it?
But then at a certain point, people just say, you know what, I'm sort of done with that. I'd rather go out and go, there's a nice movie that I'd like to see, and so.
That's great. Yes, because some grief therapists say grieving is forever. And being able to say, I want to go see a movie is fantastic. Thank you. Beautiful. And you also advocate for bearing witness rather than fixing. So we, as a collective, we must carry the awareness of these things are happening and still happen and have happened, right? How is the bear witness important for us as a society or as a group of human beings carrying an awareness?
Well, if you don't know there's a problem, you're not going to fix it.
Yeah,
So
yeah.
it's sort of the first step of
Coming
doing
out of denial and,
something.
and keeping that light
Yeah.
on the topic. Thank you. Yes, yes. Okay. Oh, sorry. So I don't want to keep you longer, but I don't know if you would like to say something more for the Spanish speakers of and readers of your book. And this is, of course, we're catching up late in comparison to the English language readers, but it's an important part of also for us and as humans, and
Well, I mean, let's face it, we're all catching up.
we're all catching up, whether we like it or not.
So,
Thank
you
you.
know, I mean, I don't even want, I think the Europeans are probably going to have to take the lead in science for a while, judging from what's going on in my country. So,
Apparently so, yes.
yeah, we're going to have a big brain drain. A lot of young scientists heading to Europe because,
Yes, yes, yes.
so, so I hope the Europeans will step up.
Yes, I hope so too, that we can stand to the challenge
Yeah.
for the world of science and the world at large. Thank you so, so much, Doctor.
Well, thank you very much.